If your lats are tight, that connects to your arm, and that has to put your shoulder in a malposition. So the point here is not to learn the names of the muscles or what exactly they do, but it's all connected. When we take a history, we need to think about sport mechanics always. And so in diving, what I want to know, I mean, I can honestly, at the risk of sounding arrogant, make most diagnoses when I get a phone call from coaches over the phone. Because if I ask the right questions, so are they having pain when they throw their fronts or their backs? Do they have pain when they're circling? Do they have pain when they're entering the water? How do they save? And is it worse on backs and gainers or fronts and inwards? And with that amount of information, I can usually tell where's the lesion in the shoulder. I can't tell about the mechanics of how the shoulder blade is moving, but if they're calling me, there's already been a positive MRI and there's a structural failure. And so I want to know where in the dive does it bother me. There are repetitive impact at high loads during entry. Forces are transmitted up through the wrist, to the elbow, up to the shoulder, through the triceps. So if there's weakness at any point, ultimately a wrist problem or wrist weakness can manifest itself as a shoulder problem. So the macro trauma that we see in divers, those are the acute injuries. Dislocation or subluxation of the shoulder, which is a partial, subluxation is a partial dislocation. Bankart is within the labrum, and I'm saying this only so you hear the words, because when you go back, you may hear these words from physicians that you're dealing with. A Bankart is when the labrum is pulled off. The capsule is the ligaments, and a Hagel lesion is when it tears off of when the ligaments tear off of the ball, not the socket side. Really uncommon. I've only seen it in one diver, but that diver dislocated at nationals, and they put his shoulder in, and as he was going to x-ray and walking to the truck where they were doing it, his shoulder dropped out, and it just kept on dropping out because it was torn all the way, it was all the way around and torn off. But frequently, the athlete has laxity, so there's a normal looseness, because I think that to some extent the athlete chooses the sport, to some extent the sport chooses the athlete. If you don't have a significant amount of laxity in your shoulders, you can't be a decent diver. But there's a continuum of laxity where it eventually becomes instability. So there's looseness that gives way, and usually it's with one trauma and the person dislocates. Slack lesion, tear at the labrum on the top, we talked about, and then rotator cuff tears are rare. I've only actually had to do a full-on repair, a full thickness tear of the rotator cuff on one person. There are partial tears, and that's very common. The repetitive microtrauma, we see subluxation events where the shoulder is coming out partially, usually because there's laxity. And there have been probably about 4 or 5 divers that have done arthroscopy on where they did not have a middle ligament. We had to make one arthroscopically. The partial tears of the rotator cuff are common. Multidirectional laxity or unidirectional laxity, which eventually becomes an instability. The slack lesions and scapular dyskinesis, which is abnormal movements of the shoulder blade. And then there's all the overuse things. Tendinitis, rotator cuff, biceps, or impingement, those are the diagnoses I usually hear on divers. If it's a young, healthy athlete and it's an itis, that's not the source of the pain. That is the source of the pain, it's not the cause of the pain. Okay, it's the consequence. The problem is if you treat the bicep tendinitis, it'll be back. If you don't treat the cause of the bicep tendinitis, it will keep coming back. Usually related to the shoulder blade not moving properly, frequently related to instability or laxity. I only know one diver that's had surgery on her acromioclavicular joint, and I didn't do that. Acromiale is a growth center in the acromion, which is the bone at the tip of the shoulder, and that sometimes doesn't fuse, and there's been one diver that's had that fused. Rotator cuff tears, usually partial thickness. A posta lesion is a fancy name for a tear on the underside that has to be reattached. So here's the arthroscopic view. Here's the ball. Socket is down here. Here's the biceps, and here's the tear in the rotator cuff. Here's another one with the rotator cuff. Internal impingement is something you read about in pitchers. It also occurs in divers, where the rotator cuff is hitting against the labrum and they both tear. Impingement syndrome, pretty common. This actually is an older diver, a former diver, where things just get ratty up on top of the rotator cuff, and there's a bone spur. sitting under here. It does not happen, we know now it doesn't happen in young people. It's usually related to shoulder blade mechanics and usually related to inability to position the shoulder blade properly or the shoulder is unstable. Instability, there's a continuum from laxity to instability, capsule laxity, we talked about a little bit, the detachment of the labrum. This is here's a normal labrum, and here's a capsule that's somewhat loose. Well, what do we see? These are all pictures from one diver, one event, dislocated from platform. It was his first shoulder injury. So here he's lying on the side, here's the socket, here's the labrum or bumper that's torn off the front. Here's the continuation of that down here where it's torn off the bottom, and here's the continuation where it's torn off the back. So he was 270 degrees, pulled it off around his shoulder. That's called a Bankart lesion. Okay, but with the Bankart lesion, not uncommon, is something called a Hill-Sachs lesion. When the ball pops out of the socket, you actually fracture the back of the ball, and this was also from the same diver, because I got him within 2 weeks after the injury. The labrum, this is actually a diver, Michelle's divers, that here's the ball, here's the socket, here's the labrum up at the top, and here's the rotator cuff. And this was with the arm in the overhead position. And as soon as I put him in a position that I was torquing his arm as if he was going to hit the water, the labrum actually peeled off. So this is a view that you don't get to see. There's no fluid in the joint, and the arm is up overhead, not in the position that we usually work. So this actually led to a test that we were doing that actually helps identify tears of the top of the labrum. And then we repair that by just cleaning up the area here where it has to be attached and sew it in. And that patient, that diver that I showed you that had the stretched out capsule here, all we do is do a plication stitch or make it clean to tighten it up. And this was back when we were using an absorbable suture material, depending on the athlete, what the demands are on the shoulder. Sometimes I'll use absorbable, sometimes non-absorbable. There are now suture materials that have a combination of the two. So here's where, this is a diver that I did actually, she was this year, that the labrum is torn off. She actually fractured the socket. This was a one-time injury, and that got sewn back, putting the bumper back up against the socket. There were other injuries with this shoulder as well. And then here's that same rotator cuff tear, where all we had to do in this case was not repair it, but just clean it up. And it's got a nice blood supply, and that'll heal very well. And then when I get done with my surgeries, everybody gets examined under anesthesia, because if it's going to fail, I want it to fail when it's in my hands, not when they hit the water. So I've got to make sure, it's very easy to make somebody's shoulder stable, just make it too tight. They have a dive again, but their shoulder won't come out. On the other hand, if you leave it too loose, they'll be able to dive and their shoulder will come out. So when my partner Scott Fisher joined me over 20 years ago and he was operating on divers with me, we had just met lunch in the late 80s and early 90s, and Scott said, I didn't know how tight to make them. The same way my mother knew how much salt to add when she made soup. Just enough. You know, not too tight, not too loose. Well, the way I know in divers is it doesn't do me any good to put them in a pitching position. Put them in a diving position. So when you're done with the surgery, you put them overhead, you load the joint and see, can I push it out? Because if you tighten the capsule at the bottom too much, then it's like a little springboard, and the diver, when they hit the water, it'll fail. And if you leave it too loose, they'll come out. So it's just a matter of getting a feel for it. And then we will refine the rehab based on the patient's range of motion and stability. So I want to make sure they've got all their range and all their stability. Which gets us to functional rehab. And it's functional rehab because our goal is to correct the mechanical flaws that cause the problem. So we want to restore I restore the anatomy. That's what I do in the operating room. I restore structure. I don't do anything to restore function. That's the physiology, kinematics, and that's restoring the sensory motor system. And that's up to the athlete. And I mean, my part's done in an hour. They've got a lot of hours of work to do. And if they don't buy in, they'll do poorly. If the coach doesn't buy in, they'll do poorly. So we want to restore the integrity of the entire kinetic chain, meaning what's going on in the legs, the hips, up into the shoulder blade, and then reestablish normal function. So coaches talk about alignment all the time. We're just machines. We're biological machines. We'll function if we're out of alignment. We won't look good. We won't be very efficient. Parts won't last as long, but we'll get there. If you have better alignment, you look better, you're more efficient, your performance is better, and you have more durability. So alignment is part of the whole concept of the kinetic chain. So the goal that we have in the phases is reestablish the proximal segment of control, meaning lower down. Then we work to scapulothoracic area. So what I keep hearing from coaches is, when can we move them? Well, I don't want a whole lot of movement in the ball and socket joint if the socket's not going to be in the right position. Get the socket in position, the ball will follow. That won't be a problem. Then we'll get control of the ball and socket, then if you won't join, and then we'll do the functional training. It doesn't matter how many reps you do if you're doing them poorly. I mean, think of a diver. If the diver doesn't have the right mechanics, does it matter how many hours they practice? No, they'll just master bad technique. And the way we can see that something's not being done properly is the shoulder fatigues. And the first sign of fatigue is they start to hike the shoulder. And you can see that on the pool deck. I mean, the only reason God gave us shoulders and elbows is so we could put our hands where we want to in space. And if you get to a point that you can't go any farther because it hurts, what do? You hike your shoulder blade. It'll get you there. But there are going to be compromises. Let's forget that. Exercises, there are open chain and closed chain. We talked about that when we saw the video of the parts of the dive. Open chain means the terminal link where the hand is free, much more stressful to the rotator cuff in the capsule. Closed chain exercises, which are great for divers. There's less shear force on the capsule or ligaments and on the rotator cuff, and it makes the rotator cuff more efficient by about 23%. So if we look down at the hips, you want to make sure that everything is done with the right alignment. So a very simple exercise to strengthen the muscles around the hip, the gluteus medius, the hip rotators. What you want to make is to have them stand on one leg and just do rotational movements. Really important for hurdle work. But it's important that they do it with the proper alignment because, again, if not, they're mastering bad technique. You want to correct the immobility in the thoracic spine early. Really common in divers. I mean, how about that pool posture? I mean, swimmers are worse than we are, but it's all in the thoracic spine. And divers lose motion in their thoracic spines and sometimes get shoulder injuries because they don't have enough mobility in the thoracic spine. So this is something we do, and we do this with a lot of athletes, but especially we started doing this with divers in the 80s, having them do step-ups. But we have them just so it's basically a neurological rehearsal, even with their arm in a sling. This is not stressful to the shoulder, but you have somebody working with their hurdle leg, so just their brain doesn't forget what it's supposed to ask the body to do when it comes time to get them on board. And there are a lot of different things that can be done. There's a sequence, I think, later. Yeah, just hang in there with me, because then the sequence later is to have people doing a hurdle with a weight in their hand. So everything that we do, we try to be functional for the specific sport. So our program in diving for post-op on divers is a lot different, I'm sure, from what's being done around the country. The unfortunate thing for me personally is I don't operate on local divers anymore. So I unfortunately have to send them back to wherever they came from, and there was only a handful of therapists that I work with around the country that work with divers that know that. So the shoulder program that we look at is working on core, working on lumbopelvic. I know that John Wingfield, from talking to him, is doing a whole lot of this. You want to do it standing, you want to do it inverted. I mean, a lot of handstand stuff. We started working with divers in a handstand position years ago. If you want to have them work with single leg, both legs, and both. I don't know if you're familiar with Bosu balls, these sort of calf sphere that we have people do balancing stuff on. But John was telling me that for his divers, he has them doing it handstands on the Bosu ball, which is great for core control, great for scapulothoracic control. So early on, we have patients in the post-op period. You can do what's called lawnmower starts, even in a sling. So it's really pulling the shoulder blade back and down, and then later on, we'll get back.